Very good afternoon to one and all. I'm Dr. Sidra Ansari, and in this session, I'm going to talk about Introduction to Orthognathic Surgery, Diagnosis and Treatment Planning. We're all aware that our face is not symmetrical, one side to the other side. There is always some amount of asymmetry present. This asymmetry makes our facial features unique and different from each other. Now, when these asymmetry are present in a harmonious relation, they impart a beautiful characteristic to your face. But what if happens? There is a deviation away from the normal, result in dentofacial anomalies. Now, we as maxillofacial surgeons see a lot of dentofacial anomalies. When we see them, we need to address them in all three planes, that is, the vertical plane, horizontal plane, as well as anterior-posterior plane. Thus, various dentofacial deformities can be broadly divided into maxillary deformities, mandibular deformities, and asymmetries. Maxillary deformities could be maxillary access, maxillary deficiency. Mandibular deformities like mandibular excess, mandibular deficiency. There could be a combination, that is bimaxillary protrusion or bimaxillary access, or there could be nasomaxillary hypoplasia with mandibular prognathism or nasomaxillary hypoplasia because of the cleft lid. There could also be facial asymmetry, which could be because of hemifacial microsomia or because of condylar hypoplasia, or there could also be hemifacial, you can say, asymmetry in the chin. Now, because of these skeletal deformity, not only the skeletal structures are affected, but the dental structures are also affected. You could have an anterior open bite or a reverse overjet or a reverse bite in case of mandibular access, and an open bite can also be seen. So along with skeletal deformity, the dental problem are also present. So in these patients, we need to adopt a systematic evaluation. Now this systematic evaluation includes a proper case history. Now case history includes general information of the patient, that is the name, age, the gender of the patient, the occupation of the patient. Along with that, we need to take history of any kind of medical condition to rule out that these dentofacial deformity are an isolated entity or they are in association with some systemic problem. At the same time, we also need to do a thorough psychological evaluation of the patient. This plays a very important role in our treatment planning. We need to know what exactly the patient wants. Sometimes the patient doesn't want to undergo orthodontic surgery, but the patient is doing under the peer pressure or because of the pressure of the patient to get a better aesthetic profile. Or sometimes the patient is doing a doctor hunting, wherein the patient would have an exceptional demand, like he or she would like to look like an actress, but whether you are able to provide that or not. For that case, you need to know the psychological aspect of the patient, because in high demand patient, no matter how much good work you do, they will always demand for something more. So you need to treat these patients more specifically and more carefully. Now, along with these general history, we need to have a complete clinical examination. Now, clinical examination involves the facial profile of the patient, the examination of the photographs of the patient. Then, along with the clinical examination, we need to have study models as well as radiographs. We will see each of these conditions separately. We begin with, as I mentioned earlier, we need to have a profile, frontal as well as lateral profile examination, radiograph and dental examination. Now, the frontal analysis or the profile analysis will start from the facial form. Now, facial form, what I mean by that is the height and width proportion of the face. Now, it is said that the height and width proportion of female is 1.3:1, whereas in male it is 1.35:1. The bizygonial width should be around 30% less than the bizygomatic width. What happens if this bigonial width is much lesser? You will have a long face, wherein this is mainly because of the maxillary access. There is deficiency in mandibular anterior-posterior position. There is deep palatal arch, and it could also be because of the narrow nose. Now, what happens if the bigonial width is more than 30% than the bizygomatic width? In that cases, you will have a short and square face, wherein there is class 2 div 2 malocclusion, you can say. Then could also be because of masseter hypoplasia. The chin is retruded because of the short and square face. Let's move on to the transverse analysis, that is to analyze the frontal profile of the patient in transverse dimension. In this case, rule of 5 is used, wherein the face is divided into 5 different sections equally part. Now these depend upon the width of the eye, starting from the helix on one side to the helix on the other side. Now it is said that the outer canthus from one eye to the outer canthus of the other eye should coincide with the angle region of the face. Now in case of maxillary hypertrophy, the angle lie away from this line. In case of long face patient, the angle lie within this line. Whereas the middle part of the fifth, that is the middle fifth of the face, is basically between the two medial canthus of the eye. It is also termed as intercanthal distance. Now these distances are normally increased in hypertelorism patient. It is normally said that this distance should coincide with the ala of the nose and the corner of the mouth. But if it is more in hypertelorism patient. Let's move on to the facial asymmetry. To assess facial asymmetry, an imaginary line is made on the face starting from the soft tissue that is gnathion, then the nasal bone, the pronasale, the philtrum and the poconion, and we check the symmetry of the face from one side to the other side. At the same time, we also have to check the proportion of the face. We divide the face into 3 different parts, that is the upper third, the middle third and the lower third. The upper third, basically if there is any kind of abnormality in the upper third, is masked by the hair. But the middle third mainly include the nose, the paranasal area, the cheekbone. Okay, now if there is any kind of abnormality in this area, you can make out. Now basically there is a continuous line. You will make a continuous line starting from the anterior of the ear going to the cheekbones coming to the base of the ala. Now this is normally in form of a continuous line. If there is a break in this continuous line, this is basically because of some abnormalities in the middle third of the face. Either it could be maxillary hypoplasia or maxillary hyperplasia or mandibular excess. Now the lower third of the face is further divided into the upper 1/3, which constitute the upper lip, and the lower 1/3, which constitute the lower lip and the chin. Then let's move on to the lip competency. It plays a very important role. The normal lip length of the upper lip is around 20 plus or minus 2, whereas the lower lip length is 40 plus or minus 2. Now in case of vertically maxillary access, the lip are incompetent. The lip are not able to close completely. Now normally there is a slight amount of gap, around 2 mm difference between the lip. But in case of maxillary excess, the lip are not able to coincide. Or in case of protrusive maxillary incisors, because of protrusion, the lip are incompetent. But sometimes there is no maxillary protrusion, but itself the lip bulk is less in that case. So you need to analyze that in case of frontal analysis. Let's move on to the profile analysis. Now profile analysis, the upper third, normally supraorbital rim, it projects 5 to 10 mm beyond the most anterior projection of the eye in most of the cases. But in case of deficiency, this may be moved behind, or because of exophthalmos, the patient is suffering from a systemic condition. Because of exophthalmos, this could be altered. Now the middle third of the face, it contains the nose, the cheek, the paranasal area. Now this profile analysis is very important to assess the maxillary hypoplasia and mandibular excess. As I mentioned earlier, you make a curve starting from the ear, the cheekbone, the alar base, and to the corner of the mouth. Normally it is a continuous curve, but if there is interruption in this continuous curve, okay, if there is interruption, either it could be because of maxillary hyperplasia or because of the mandibular excess. Then come the lower third of the face, which include the lip, the labiomental fold. Lip, we check for the competency of the lip. The labiomental fold we check is basically the angle between the subnasalis and the upper lip. Now this labiomental, that is fold, will tell you the projection of the incisor and eventually the position of the lip on the incisors. Then come the nasolabial angle, then the chin and the chin throat angle. Normally the chin is receded in case of a micrognathic mandible and in case of TMJ ankylosis. Now here the chin throat angle is also decreased. Now let's move on to the cephalometric analysis. Now in cephalometric analysis, we do analysis of both soft tissue and hard tissue. So there are certain points and planes that you need to keep in mind when you are talking about cephalometric analysis. The soft tissue points include G, that stands for gnathion, soft tissue gnathion, that is the most anterior point on the front forehead. Then nasion, soft tissue nasion is the deepest concavity between the frontal bone and the nose. Now soft tissue soft tissue PN is nothing but the anterior-most point of the tip of the nose. Then subnasalis is nothing but the junction between the base of the nose and the lip. Then you come the pogonion is the anterior-most point on the soft tissue chin, and menton is the inferior-most point on the soft tissue chin. Let's move on to the planes of soft tissue analysis. Okay. The first one is the facial plane. It starts from the nasion to pogonion. It's a line drawn from nasion to pogonion. Now this facial plane is further divided into upper third, upper facial plane and lower facial plane. Upper facial plane start from the gnathion to the subnasalis, and lower facial plane start from subnasalis to pogonion. Then you have the S line, which is nothing but a line starting from pogonion to a point between the subnasalis and the pogonion, that is the tip of the nose. Then you have an E line, that is all aesthetic line, which is a line joining the paranasalis, that is the and pogonion, the tip of the nose and the pogonion. Let's move on to the hard tissue, that is marking. That is the bony marking that you see on the lateral cephalogram. Okay, as I mentioned, G is the gnathion, that is the anterior-most point of the forehead. Then N is the nasion, that is the frontonasal suture. Then OR is the orbitale point, that is the intraorbital foramen. S is the sella turcica, that is the wherein the pituitary gland is placed. And anterior nasal spine, posterior nasal spine. Point A is the deepest point in the maxilla in the midline, whereas point B is the deepest point in the mandible alveolus in the midline. Then you have pogonion is the most anterior most point on the chin. Menton is the most inferior point on the chin, whereas gnathion is the anterior inferior point on the chin. Gonion is nothing but a point of intersection between the mandible and the ramus. Now these are some of the hard tissue plane, wherein number 1 is the HP plane on the cephalogram, which is nothing but a perpendicular drawn to the most prominent line on the cephalogram. Below that, number 2 is the constructed HP plane. This is actually a line drawn at 7 degrees to the SN line or SN plane. But what exactly is SN plane? SN plane is the line joining the sella turcica and the nasion. It tells you about the anterior cranial base. Then we have the plane 4, which is nothing but basion and the nasion. Now this plane separates the skull from the face. Then you have point 5, that is the Frankfurt horizontal plane, which start from the orion to the external point of the external auditory canal. Then you have point 6 is nothing but, you can say, pterygomaxillary fissure. You draw a line perpendicular that is parallel to the true vertical line. 7 and 8 are the occlusal plane, and 10 is the mandibular plane. Now, all these soft tissue markings and hard tissue markings are helpful to do an analysis of the facial skeleton so that we can carry out orthognathic surgery. One of the most commonly used analysis are Down's analysis. Now, this is based upon 10 parameters. It has 5 skeletal parameters and 5 dental parameters. Now, each of these parameters we look separately. The first one is the facial angle. It is the internal inferior angle formed by the Frankfurt plane and the line joining the nasion and pogonion. Its average value is 87.8 degree, whereas the range is 82 to 95 degree. It basically tells us the relationship of the lower face, that is the mandible, to the maxilla. Now this angle is increased in case of maxillary prognathism, and it is decreased in case of a class 2 profile. Now the next is the angle of convexity. Now it is the angle formed between the nasion and point A and from point A to Pogonion. The average value is 0 while the range is between minus 8.5 to 10. Now this basically tell us whether the profile is concave or convex. If the angle increase, the profile is more convex, which is seen in case of bimaxillary protrusion. If the angle become more negative, that is the profile is more concave, which is seen in case of mandibular prognathism, that is class 3 occlusion. Then we talk about AB plane angle. It is also called as facial plane angle. Now it is an angle formed between point A and B to nasion to Pogonion. Okay, it is normally a negative angle. Its average value is minus 4.6 degrees, while the range is minus 9 to 0. A negative angle is more normal. The angle become more positive. That means if it becomes more positive, the maxilla is anterior. That is class 2 cases. And if it has become more negative, it is more normal. That is more prognathic. Then we come to mandibular plane angle. It is an angle formed between the Frankfurt plane and the mandibular plane. Its average value is 21.9 degree and the range is 17 to 28 degrees. Now this basically tells us regarding the growth pattern of the mandible, vertically growth pattern of the mandible. Then we come to y-axis. Now it is an angle formed between the horizontal plane and a line from the sella to the gnathion. Its value is around 59 degrees and the range is 53 to 66 degrees. Now this basically represents the growth pattern of the patient, whether the patient is a vertical grower or horizontal grower. The angle increase in case of vertical grower and the angle decrease in case of horizontal growers. Now we talk about the canth of the occlusal plane. It is the angle between the Frankfurt horizontal plane and the occlusal plane. Now its average value is 9.3 degrees and the range is 1.5 to 4 degrees. Now it basically tells you the inclination of the occlusal plane to the Frankfurt plane. Now the another analysis is interincisal angle. Now basically it is the angle formed along the long axis of central incisor of upper and lower teeth. The average is 135.4 degrees and the range is around 130 to 150 degrees. Now if this angle increases, that means there is maxillary hypoplasia or mandibular prognathism. In case of class 3 profile, the angle will increase. The angle will decrease in case of class 2 profile, that is bimaxillary protrusion. Class 2 profile, class 2 division 1 cases. Then the other is incisor occlusal plane angle. It is an angle between the long axis of the lower incisor to the occlusal plane. Now its average value is 14.5 and the range is 3.5 to 20 degrees. Now this basically tells us the proclination of the lower incisors. The other one is the incisor mandibular plane angle. Now it is an angle formed between the vertical axis of the lower incisor and mandibular plane angle. Now its average value is 1.4 degrees and the range is minus 8.5 to 7. The angle decrease in case of mandibular retrognathism, okay, that is the incisal inclination decreases. If the incisal inclination of the lower incisor increase, the angle will increase. The other part of the Downs analysis is upper incisor to epoch line. Okay, upper incisors, it is a linear measurement from the epoch line, that is point line A to Pogonion. You will draw a line perpendicular to it to the incisal edge. This will basically tell you about the overjet of central incisor. Its average value is 2.7 mm and range is minus 1 to 5 millimeters. Now after cephalometric analysis, dental examination or dental study models are very important. Now this helps us to know the alignment of the dentition. Also tell us about the anterior-posterior relationship of the dentition, help us to evaluate the bite of the patient, check the transverse relationship as well as the functional occlusal issue, check this curve of Spee, and basically they simulate the patient when the patient is not there in your clinic. You could do your study model or mock surgeries on these model, and then you could stimulate the result on the patient. With this, I would like to conclude by saying that diagnosis involves development of a comprehensive database of parameter information. The data is derived from case history, clinical examination, and other diagnostic aids like study model, cast, radiographs, and photograph. But a systematic approach to the examination is very essential to ensure that you have a better outcome of surgery. So your mock surgery and planning is essential before you offer a surgery. Thank you.